Good morning. Thank you for inviting me to present this talk today. My name is Terese Hammond. I'm an adjunct associate professor of clinical surgery at the University of California, of Southern California, and I'm also the medical director for the intensive care unit at Providence St. John's Health Center in Santa Monica. And today we're going to be talking about OSA therapies that reach beyond CPAP and oral appliances. I know that you have separate presentations for those two topics. I'll just say that while I was a co-investigator for the Inspire Upper Airway Stimulation System, the post-approval study, while I was on full-time faculty at USC, I received no financial or salary support, and I'm not involved in that study at this time. So we have a relatively brief time to spend together today, and over the next 30 minutes or so, I'd like to sort of focus on a few specific objectives. First and foremost, I think it's important that we look at the upper airway and phenotyping and how important that is to the treatment, the successful treatment of obstructive sleep apnea. Also look at some non-PAP therapeutic options, specifically surgical or behavioral options. Try to understand the importance of patient selection in the treatment of OSA, and then look at combination therapies, how we can take non-PAP therapies and combine them with other modalities to provide a patient-centric treatment program. Now, not everybody who snores has sleep apnea, clearly. And sadly, not everybody with significant sleep apnea can tolerate CPAP. And we know from decades of evaluation, of rigorous scientific evaluation, that CPAP is clearly the most efficacious therapy for most patients with sleep apnea. But it's not always the most tolerable. And we know that even on the night of a sleep study, when a patient carries a negative perception of CPAP away from them, that in turn will predict their ability to use CPAP in subsequent weeks and months. So those people that walk out with a high negativity score or have a very poor opinion of CPAP during an in-lab sleep study will have a much lower chance of effectively using CPAP for 4 hours or more on most nights. And when we look at the long-term adherence to CPAP, we know that it's a significant issue. So even if initially patients are able to use CPAP, being able to sustain this, being able to sustain the behavioral changes, it's very difficult for US adults. Now, in the past, we could make a pretty compelling argument to patients with concomitant cardiovascular disease that treating their sleep apnea could improve or decrease their chance of, improve their cardiovascular condition, their cardiovascular health, and decrease their chance of subsequent cardiac events. However, when SAFE came out a few years ago, that really sort of cut to the heart of CPAP as secondary prevention for cardiovascular disease. Now, we all know that there are multiple problems with this trial, and that for patients with moderate to severe sleep apnea, CPAP is still efficacious in what we should suggest. However, it did take away one of those layers of compelling arguments that we could make with patients, especially patients that didn't have daytime symptoms, that weren't sleepy during the day. Now, the vast majority of sleep apnea remains undiagnosed. If we think of 4% of men and 2% of women having at least mild sleep apnea, we're really looking at mild symptomatic sleep apnea. We're really looking at a significant number of patients in the U.S. population. And with COVID, I think that this is becoming an even bigger challenge, not only in terms of diagnosing patients, but also compelling and encouraging them to use their devices. But what do you do for the patients that aren't able to tolerate CPAP? So even under the best of circumstances, we know that 20 to 30% of patients with significant sleep apnea are not going to be able to make that 4 hours or more per night on most nights threshold for CPAP compliance. Where do you go from there? Well, even Colin Sullivan, who invented CPAP, in the 80s. The initial device was described as a pump powerful enough to run a swimming pool. And the initial sleep study, this is actually from his paper, or a retrospective paper on his process of evolving CPAP as a therapy for sleep apnea. You can see very uncomfortable, even today, described as very uncomfortable by the majority of patients. And even though interfaces have improved a great deal, it still requires a certain amount of commitment, resiliency, and behavioral change for patients to tolerate CPAP. So where do you go with those patients? The patients that just cannot tolerate CPAP but have significant sleep apnea. Well, I think probably the first part of that question is understanding that patients are heterogeneous. There are different reasons that each patient has sleep apnea and different approaches that are likely to be most beneficial for them. And part of that's, that argument sort of starts by looking at the anatomy of an individual's nasopharynx. And so the place that we start with these non-traditional or non-PAP therapies is trying to phenotype a patient's airway. Now, we know a multitude of things go into successful treatment of sleep apnea, and probably a lot of these characteristics of an individual patient need to be weighed more heavily in deciding what therapy would be appropriate and most likely to succeed. Just because CPAP is the most efficacious treatment, that it can reduce the AHI by the most amount, doesn't necessarily mean that it's the most beneficial treatment for every patient. If a patient, for example, can wear an oral appliance for 8 hours a night versus a CPAP for 2 hours a night, where is the benefit there? And so that's why we have to sort of broaden our concept in our mind to incorporate other modalities for the treatment of sleep apnea in patients that just can't tolerate CPAP. Now, how do you phenotype the upper airway? We use sleep-induced sleep endoscopy. Basically, give something like propofol to simulate sleep, and then use a fiber optic endoscope to look and see what happens to the airway when the patient is sedated. And these patterns of collapse have been characterized and constructed into a validated scale, something called the Vogt scale. So based on how the posterior pharynx, the tongue base, the epiglottis, the vallecula appear during sleep-induced sleep endoscopy, you can make predictions about what types of therapies, specifically what types of non-PAP therapies, can be beneficial. And frankly, as we look at these patients, many of these patients have multiple layers of pathology. So it's not just about one particular area of their airway collapsing. They can have multiple areas that play a part in the severity, the appearance and severity of sleep apnea. Now, we know from studies, more recent studies, that the use of dyes can impact what types of procedures, specifically surgical procedures, are recommended. And again, the future of sleep apnea is probably in these combination therapies, so multi-level, multi-efficacy interventions, surgical interventions that treat an individual's anatomy associated with their sleep apnea. This is a low Tesla high-speed MRI. It's something that we did at the University of Southern California to dynamically look at airways during sleep. This was a simulated sleep with, again, with propofol, and you can see what happens to the airway in this situation, a concentric collapse. So, ultimately, as imaging techniques have wider availability and have become cheaper, there may be alternatives even to the process of sleep testing or polysomnography. So in terms of non-PAP therapeutic options for sleep apnea, we're just going to look at a couple of things, actually. We're going to forego more discussions about oral appliances because I think that's covered in other areas. And we're going to really hone in on sort of behavioral and surgical options. Now, we know that a 20% weight loss can decrease apnea-hypopnea index, around 40 to 50%. The problem with weight loss, though, is it depends on where you start. So if you start with an apnea-hypopnea index that's severely elevated at 60 and you decrease it by 50%, you still have severe sleep apnea. And in fact, in most of the studies that have been done in bariatric patients pre and post-operatively, they do get significant decreases in AHI, significant improvements in sleep apnea, but most patients still have residual disease. So it's important to bear this in mind. Positional therapy in about half of patients, positions make a difference in terms of severity of sleep apnea. About half of patients have more severe sleep apnea on their back versus their side. And so using positioners can, again, like weight loss, decrease the severity of sleep apnea, although it depends on where your starting point is. And we've come a little way from the traditional sort of tennis ball and a t-shirt positional therapy. There are devices, including Bluetooth devices, that can vibrate or signal something to wake people up when they roll on their back. But the concept is still the same, trying to avoid supine sleep. Surgical options have gotten a bit of a bad name over time, mainly because they were very, very heterogeneous and lumped together when the initial position papers on surgical treatment of sleep apnea were done in the early 2000s. Now with DICE, we can more specifically target areas of the airway, and I think we're going to see going forward some better outcomes. But again, this is very individualized, and I think a harbinger of how sleep apnea therapy has to move to a more specialized, personalized approach. And again, sleep apnea options. Traditionally, we said that surgery had a 50% chance of decreasing the AHI by 50%. That, again, with DICE has probably been improved in a cohort of patients. Although, again, it really depends on where you start from. If you have an AHI that's severely elevated, even the best non-PAP therapies may still leave residual disease. So let's talk a little bit about hypoglossal nerve stimulation. This is the FDA-approved Inspire device. Essentially, it's a pacemaker-like device that's implanted under the skin, and then leads go to both the intercostals and the hypoglossal nerve. On stimulation, the tongue bases or the tongue is moved forward, and the palate or the tongue base can be opened up. And again, these two leads, one lead goes between the intercostals, and it can sense inspiration. So this device is turned on at nighttime with a remote control by the patient. When they fall asleep and they inspire, that's sensed by the generator, and a stimulus, a milliamp stimulus, is given to the hypoglossal nerve. It's titrated over several visits to be able to move the tongue forward appropriately and open up the airway. And here's a polysomnography recording of pre and post activation of the hypoglossal nerve stimulation. You can see in this patient prior to the device being activated, they have significant obstructive sleep apnea, decreased flow with continued respiratory effort, and severe desaturations once the device is turned on. And in this case, their threshold was 2.5 milliamps. This was turned on, and on inspiration, the stimulus was given, and the sleep apnea was significantly improved. Now, we have some relatively good data that has been obtained over time. The original STAR trials, 12, 24, 36 months data, showed improvement, but now we've been able to record data out 5 years on the original cohort of 200-odd patients. And you can see that not only has Inspire proved efficacious in the majority of patients that are carefully screened for it and implanted, but that efficacy has sustained over time. And more importantly, softer outcomes like patient report of daytime functioning has improved and remained good over the 5-year period, as has their sense of symptom improvement. and their comparison, the patient comparison with other therapies like CPAP. Most of these patients had prior exposure to CPAP, and so it's that comparison. Now, there are some side effects from these therapies, these surgical therapies, although they tend to improve over time. So things like tongue weakness or swallowing or speech impairment, some of the discomfort that patients feel immediately post-operatively tend to wane over their visits. Their 2-week, 1 month, 3 month, 6 month visits. In general, the side effects have been relatively mild and relatively palatable for the patients. So you have these alternative therapies, and we don't have a smart card like we do with CPAP. So how do you compare them? Specifically, how do you compare the overall benefit of an oral appliance to CPAP when we know that efficacy is different, but the period of time that a patient can wear it is also different. So there are devices that are being incorporated into some of these therapies. Obviously, the Inspire device has a recording, including a patient interface that can report usage time. Things like oral appliances, there are these sophisticated sort of buttons that can be implanted into oral appliances that record length of use, and all of that becomes important again. And in therapies that aren't as efficacious as CPAP, what is the trade-off? Is wearing something or using something 6 to 8 hours a day with lower efficacy better than using something like CPAP that's very well validated in terms of efficacy, but can be difficult to wear on a consistent basis, so compliance can be difficult. Those are all questions that we're starting to answer as we use more and more of these non-traditional therapies. And then there's the SomnoMat. This is actually Colin Sullivan. You may recognize, the inventor of CPAP. He embraced this SomnoMat, which actually is being used for alternative things now, but it's sort of a device that's placed under the sheets that can record things like position and snoring and leg movements, and is sort of a out of the lab way of looking at efficacy in non-PAP devices. It's actually been incorporated into other things. It can sort of turn and rotate and rock patients. So this concept of having sort of an interface in the bed is something that's being actively evaluated. And then you see a variety of yet newer and as of yet not fully validated therapies. This is called the WellU O2 ring. It's like a ring that you wear on your finger. It records oxygen saturation, sends them through Bluetooth to a cell phone, and also at certain levels of desaturation, it can provide buzzing or vibration that can wake the patient up to terminate a sleep apnea event. So that's sort of the concept here, and there are a variety of different ways that this is accomplished with different types of devices that can be on the wrist or at the bedside. So a variety of different things that we still need to validate. But, I think, again, the overwhelming message that I'd like to leave you with during this presentation is that the future of sleep medicine is like the future of sleep medicine in respect to obstructive sleep apnea is likely to rest on our ability to incorporate multiple modalities. So it's not just going to be about, one treatment and one disease anymore. OSA equals CPAP. I think we've moved beyond that point. We have to address the percentage of patients that are unable to tolerate CPAP. And with that in mind, I think we're going to have to use many modalities to get this percentage of patients that are unable to tolerate CPAP an effective treatment for their sleep apnea. That may mean using things like acetazolamide or sedatives to increase the arousal thresholds. There are topical airway stimulants, medications that are starting to be validated and used for sleep apnea. And then combined with things like positional therapy or hypoglossal nerve stimulation, it's that combination approach that's probably going to be the most potent in this group of patients. And again, when you sort of model this, frankly, there have been some models, including this one that Owens et al. Published in Sleep, where they look at the efficacy of these combination therapies. And frankly, these models actually predict that a majority of patients with treatment-resistant or CPAP-resistant sleep apnea can be effectively managed with non-PAP therapies. And I think that that's true. Again, it's about individualizing and personalizing the delivery of sleep apnea modalities to these patients. So let's just spend a couple of times sort of summarizing what we've discussed in this brief lecture. Again, I think the take-home point here is that obstructive sleep apnea is increasingly recognized as a broad heterogeneous disease. So sleep apnea in one patient may not necessarily be the same and be treated the same in another patient. You take the third of patients with obstructive sleep apnea that are non-obese. Their disease is probably functionally, anatomically, physiologically somewhat different than a patient with a very high BMI that has sleep apnea solely on the basis of their weight. So it is important that we move to a more personalized approach to sleep apnea management. And I think that both DICE, which is being used much more extensively, and things like dynamic MRI and other sort of out-of-hospital techniques for defining disease are promising, and I think that it's going to help us phenotype these airways, both in adults and children. Again, no one will argue with the fact that CPAP is the most efficacious treatment for obstructive sleep apnea. If you have moderate to severe sleep apnea, it's still hard to argue with initial trial of CPAP therapy. But for those patients, that 20, 30, 50% of patients who find it impossible to maintain long-term compliance with CPAP therapy, we have to have another answer. We have to have another way. And I think that that's what I'm trying to get across in this lecture. And frankly, I think the future of sleep medicine is really heavily weighted on using these combination therapies, so using a variety of different techniques to bring the treatment plan to an individualized treatment plan to the patient. And this may include surgeries to improve the anatomy, oral appliances or medications to change either the apnea threshold or the arousal threshold, and then possibly CPAP on top of these things. So it's really a combination approach. And with that, I will stop. Thank you very much for your attention, and I hope you enjoy the rest of the conference. Thank you.